So that's what we say. He's not from SMU, he's from UKZN. That's the introduction I wanted to say, so that I am not accused of only highlighting SMU, but acknowledge that there are also other universities that have managed to compete with SMU. Yes. UKZN has managed to produce a Minister of Health. Yes. Colleagues, as we remain disciplined to welcome the Minister, it is only correct and procedurally important that we welcome back to the podium the MEC of Health from Gauteng to introduce the Honorable Minister.
Thank you, colleagues, and you may be seated. Minister, and he's always on time. We figure exactly we knew that he will come and address us, but he won't be leaving again. You all know him. He is a former Minister for Home Affairs and it's yeah, I run that campaign about Mabahambe, but and he has made a huge change in Home Affairs if you can visit the offices. Now, and he was our Minister with Department of Health, almost 10 years, 10 years, he was the former MEC, Limpopo. He started indeed a KZN, which means the KZN produces almost all those ministers as a corner, including other leaders in our country. So, Baba, you may come and address us as SAMSU. See, I launch on Sunday, it's a new baby. All provinces are here. They are waiting for you. They do appreciate the support that you are
Thank you very much. Thank you. Program Director, the leadership of SAMATU, all the leadership, allow me not to go through them one by one, but just say all protocol observed. And our guest students, who are the subjects of this gathering here today, good day to you all. Good day. Good day. And how are you? Thank you. I do not know what this story about UKZN is. I just had some excitement. Yeah, but what I know is since the era of democracy in South Africa, since 1994, there's been 6 ministers of health in South Africa. And only one of them was not from UKZN. I'm just giving you a fact, I don't know. I'm not saying anything, I'm just telling you what happened. I'm just telling you facts as they are. Yes, that's just a fact. I don't know what it means, but it's just like that. But anyway, let me start, because of the nature of the job that you are doing or what you are going to do. Let me start by giving you my story. I'm of the generation of 1976. Yes, you all know what happened in 1976. The Soweto uprisings of students, which changed the country. And part of the reason that South Africa is a democracy today was because of that action. which means I was an angry young person. That's all, I'm angry, because during the week of June the 16th, I was not in Soweto. I was in a boarding school somewhere around Polokwane when it was still called Petersburg. And I had to sleep in a tree that night. So there's no way you can forget this type of things. Because there was a Colonel Van Zyl who came to attack us. From there, I could not get UKZN because my father had no money to send me, and I didn't receive a bursary. There was no NEFSAS during that time, such that if you come from a poor family, you've got NEFSAS. But I was having an admission to medical school, but I couldn't get in. I went to teach as a private teacher for 1 year, earning 90 rand per month, which was never not nearly enough for me to save to go to medical school. But anyway, I spent that year teaching. Then I applied again to UKZN, who had already admitted me. And the response came, said, no, we no longer allow Africans in this university. Please go to Medunsa. Sefako Makgatho was still Medunsa. Not because there was anything wrong with Medunsa, but because University of KwaZulu-Natal started in 1963. Because all the others were white. UCT, Wits, Pretoria, Stellenbosch, Free State. And they said, no, let's start a white faculty. A black faculty in this white university. And that's how UKZN was started. Specifically for blacks, for Africans rather. We're regarding ourselves all as black. For Africans, Indians, and coloreds only. No white person was allowed there. Only these 3 racial groups were allowed in Natal. And the founding documents said they want to train young Africans to assist European doctors. That was the reason why University of KwaZulu-Natal was found. And almost many black universities were found like that. But anyway, whites were not allowed. So after 20 years, there was a complaint from white communities why they couldn't be allowed in a university in their own province. But of course they were ignored. Apartheid would not like you to mix races, so they could be listened to. But then, apartheid itself did not like to mix races. Anyway, apartheid was a separation of races anyway. So mixing people was anti-apartheid. You couldn't do it. They will be contradicting themselves. So they took a decision that medical students should never be mixed. And so University of Durban, Westville was for Indians. And they were already deciding to open a medical faculty there. There was already a department of anatomy and physiology to that effect. University of Western Cape was for colored people. And they said all colored people must go there. And there was already a department of physiology and anatomy. Now, Sefako Makgatho, which was called Medunsa, Medical University of Southern Africa, had just started a few years previously. And they said all Africans will go there. That's why they couldn't admit me. But there was a big strike by medical students at that time. They couldn't accept it because they knew it was wrong. But anyway, I was forced to go to University of the North, which is now University of Limpopo. I was forced to go there and do my first year. But because of that strike, I was readmitted for second year at University of KwaZulu-Natal. So you must understand my level of anger. At that time, I'm no longer angry, of course, at my age. Now I arrived at University of KwaZulu-Natal. It was still called University of Natal Black Section. There's a team of people from Johannesburg, a goal, as we used to call them when we were in Natal, led by Aubrey Mukwege. They were going to launch a Release Mandela campaign. At that time, Mandela was very much still in jail. He was still a prisoner. And now they had launched Release Mandela campaign in Johannesburg. They were going to launch it in Durban so that it spread around the whole country. And they chose medical school for the launching. Now, one of the people who was with Mandela in jail, who was a Rivonia trialist, because I think you know about Rivonia trial, who was tried at Rivonia with Mandela and sent to jail, is my uncle, whom I've never met. Because when he went to the island, I've not even started South A in 1964. Now, they launched a campaign for him, for Mandela, and obviously also him to be released. There's no way I won't get interested in that. But that's not what, anyway, I attended all political activities from University of Limpopo, because there it was war, real war, where after every June the 16th commemorations, you know that some students will have to be arrested, because they'll have a mass meeting, and out of anger, one of them will shout, "Direction!" And the rest will say, "Police station!" And without planning, they will march to the police station, where, of course, they will meet police, they will clobber them and arrest them. It was a heavy thing, which you used to do. Now, obviously, you then hate white people because apartheid is making you to be enemies. Now, I'm surprised in this Release Mandela campaign, which is being launched. One of the speakers is Professor Saki, a professor of orthopedics, who was then the dean of medical school. He is the speaker in a campaign to release Mandela. And those things to me did not match. Because where I come from, all whites are enemies. That's number one. And academics are also enemies anyway. So this one is white and an academic. And he's coming to address a campaign to release Mandela from jail. I said, there's something wrong with this institution. Because at University of Limpopo then, it wouldn't happen. It was just from the time a gentleman called Johnson made a statement. He was a professor of mathematics. He had just made a statement that it's not his fault that African students are failing because blacks are genetically engineered not to understand mathematics. And one student, out of anger during the protest, poured acid on his face. So it's war, it's war. You are enemies, you are being taught by enemies. Or you have got people who are supposed to be guiding you, regard them as enemies. Now here is one of the enemies coming to address a campaign to release Mandela. That was too much for me. But my curiosity even grew. I was not about to miss that meeting. So I went. Aubrey Mukwege spoke. Of course, he spoke politics and slogans. I understood very well. Nothing new. I was waiting for Professor Saki. I want to hear what this white man enemy is going to say. And he stood up, he said, look, I'm a professor of medicine. Well, not the department, I'm talking general. I'm a professor in medicine. I'm working here in Kenya at the 8th hospital. It is always full There are people who sleep below the beds because a lot are already sleeping on the floor. And when I examine them as a professor, I'm going to have to kneel down, take them out of the bed and examine them. And quite a large number of them are kids with kwashiorkor, which is not a disease but hunger. But I'm required to treat them. When I was only taught to treat diseases, not hunger. Yes, doctors are never trained anyway to treat hunger. Well, when it becomes kwashiorkor, it goes to become a disease, but basically it's hunger. And he said 5 kilometers down the line, there's Arlington Hospital, which under apartheid is classified wise. And he said most of the time it's empty. The beds there are empty. There are only a few white elderly people who are coming there because they've got osteoarthritis and they want their nails to be clipped and all that. Not very serious in other words. And he said, I can't use those empty beds for these people who are sleeping under the beds and on the floor. I can't. As a white person, I'm allowed there at Arlington Hospital. So I can see patients on both sides. But I can't let these two sides share resources, even though they are within borders of the same country. Because I'm not, apartheid doesn't allow that. So I'll have to do with these people who are sleeping under the beds, I'll have to kneel. And then he went on to say, you see, my professorship cannot help in this situation. It's hopeless. I can't change anything. No matter how many times I become a professor in medicine, I'm not going to change this thing. The only person who can change this situation, in my belief, I'm quoting what he said, is Nelson Mandela. I want him to come out. So we start a new country, and this type of situation can change. Because I can't change it with my professorship of medicine. You know why I'm telling you this story? It's because it gave me a direction as a medical student where I must head to. It placed me in this war of liberation. And it made me realize that this is not about white being enemy. It's a system that must be fought by both black and white. And Professor Saki is one of those who's prepared to help us fight that system. Of course, then I got to know him as a person who was not pretending, who was really part of anti-apartheid forces at that time. But it gave me direction. And in 1982, I was sent to Ngoya, University of Zululand, to speak. It was Steve Biko's day, because it was September 12th, the day on which Steve Biko was killed. And after speaking, they said, how? We thought people who can speak this type of language are only lawyers. We thought medical students know nothing about this. How wrong were they? They were very wrong. Now that's how I grew to be an activist. And of course, during our time, there was no way of not joining ANC underground and work there as a medical student during the day and do other things during the night. It was part of our life. Anyway. Now today you are here. It is 30 years after democracy. Mandela had been out and he did what Professor Saki was professing that he must come out to do. We've got a new country. But in this new country, we've got a new apartheid now. Apartheid in healthcare. That does not depend on the color of your skin anymore, but it depends on the depth of your pocket. We are back to square one. Now, before I present, we have already seen NHI there, so I'm sure you know what I'm going to talk about. How do I move this thing? Okay. Yeah, can you go to the next slide? Yes. Move. Yeah, stop there. No, go back. Yeah. Now, you see, you are lucky. And I've already told this to the media when they were asking me. They like doing that after you have been appointed in a department. What are you going to do for the first 100 days? What are your priorities? What is that? You know, I just said, you see, in medicine, in health, we are lucky. Because the World Health Organization has already defined what a healthcare system is. It's not guesswork. You don't have to guess when you go to work. The World Health Organization said a healthcare system consists of 6 building blocks. You can call them pillars. And they argue that if you follow these pillars, you'll be able to run a healthcare system very well. And if any one of these pillars is lacking or is weak, the population will feel it. They all know that is a pillar. They know nothing about pillars. They are not you. They are not medical students. They are just ordinary people. But they will feel that something is wrong in the manner in which you are receiving health care in this country. They will feel it. It will slip over into the media, and the media will project it as failure and all that. But those of us who are in the know, we will know that one of the pillars has been shaken. Now, the first pillar is leadership and governance. How is the healthcare system led, and how is it governed? That's why you, as medical students, you don't regard yourself as just being trained to know how to administer injections and other drugs. You are also being trained to be a leader, so that you are able to come and lead the healthcare system. That's why the issue of leadership and governance is so important. The second one, which I'm sure naturally you will have thought, yes, it's understandable. It has to be a pillar. Access to essential medicines and other commodities. There ought to be essential medicines in South Africa. And there must be many other commodities which are enable you to run healthcare. That will be equipment, facilities, buildings, needles, syringes, and all that. And X-ray machines and all those things. There are other commodities which enable you to run a healthcare system. The third one, the World Organization called the health workforce. We simply recognize it as human resources. Health workforce. That's what you are training to be. To be the soldiers in this war. To be one of the pillars. One of the building blocks of a healthcare system. That's what you are being trained for. But you know you have got other people in the health workforce. It's not only doctors. In fact, nurses will be the backbone of that health workforce. But you'll also have pharmacists, physiotherapists, radiographers. You'll even have cleaners and security. They are all part of the health workforce. Because, of course, in a war, you don't need only soldiers. You need cooks and all sorts of people. It's a workforce. Then the fourth one, I put it in red. For reasons I'll come to later, is the health system financing. This health system you're running, how is it financed? And let me make it clear to you, it has got nothing to do with the budget that you get from the state. That is what confuses many people. And I'm going to have to clarify that, I have to clarify that in simple way. Health system financing How is this healthcare system financed for the population? The fifth one is health information system. Very funny, I still don't understand it. But it's happening in this era and time. Some of us were born before technology. You guys, you can't live without technology. You can't live a single day without a cell phone, all of you. Or without your computer or your iPad and all that. You can't. Yes, I lived through them without anything. Yes, when I opened my practice, we didn't even have computerized landlines. You had to take a phone and... Yes. I was in a place in Sukune called Jim First. And my number was number 8. Then when they respond to Jim First number 8, and then you give them the number, they must connect you and come back after 30 minutes. And you are connected. That's how I started my practice. Now, since that time, it looks like it's a million years ago. Because technology is advanced. But one of the reasons why welfare organizations with that health information system is still a problem around the world. And what do we mean by that? Today here in South Africa, if you go to a hospital, whether it's public or private, or a clinic, or you go to see a doctor somewhere in private, if after living there, you visit the very next hospital, or clinic, or another doctor, everything will be started from the scratch. Because they won't know anything about it. If an investigation will have been done, I learned that in a hard way. When I started operating my practice in the 90s, that's when HIV/AIDS started biting. In the rural hospitals, we didn't even have facilities to diagnose HIV and AIDS. So we had to send here to Garangua Hospital. That's why it was still called. The name George Mukari came later. And it was still Garangua Hospital under Medunsa. We have got to send here. If it's not an emergency, you apply and say, I've got this type of patient, you describe your findings, and you are saying, look, I'm applying for this patient to come there. And they must respond to you. Only when it's an emergency, you get an ambulance you send directly. So I applied for him because I was clear that this person who is in front of me in the practice is HIV positive. Somebody who got in there is HIV positive. Then I said, no, let me apply for this poor person to get treatment. Because we couldn't even treat HIV/AIDS in rural areas. 2 weeks later, the response came. It said, how? But this is our patient. He's already on ARVs. Yes. That's the simplest way to explain the problem of a lack of health information system. And well, maybe you'll ask another ancillary question. Why then was he coming to me and allowing me to apply? Yes. As doctors now, it's got nothing to do with health information. I'm just informing you because these are some of the things you met. At that time, HIV/AIDS was a new disease. Nobody accepted it. There were lots of rumors about it. So people who were diagnosed positive believe if I move from one doctor to the other, there ought to be one who will find it to be negative. So I must keep on trying. You know, maybe one of them one day will tell me, oh, this thing is negative. So that's what that person was doing anyway. But because of health information system, we had to waste time. And we are still doing so, even up to today. There's no connection between one doctor and the other, between one hospital and the other, between public and private, private and private. There is no connection. And you know what it does to the cost of healthcare? Sky high. Because you are doing same thing to the same patients. You are doing same investigations. You are giving same, you know. So it's a big problem. But funny enough, many countries are still struggling. We have tried to fight. We went to CSIR the Center for Scientific and Industrial Research. We asked them to develop a homemade system We have got it now. We are piloting it somewhere in the Free State, between private and public. So that South Africa must have health information system, which as you move from one doctor to the other, they all have access to your information. Needless to say, it's going to revolutionize the healthcare system. So it's an important building block. The last one is health service delivery. What does health service delivery mean? It means the packages through which the population receives healthcare from your system. If a woman is pregnant, what is she going to receive from the healthcare system? How is the healthcare system going to send such a, to help such a woman until she delivers a baby, regardless of which family she comes from? She's pregnant. She's a human being, is pregnant. What is there for her? When the baby is born, what is there for the baby from the healthcare system? To develop that baby into a medical student. What is that baby going to receive? I used to have a lecturer who, Mr. Pizzo, from the Free State, unfortunately he's late. He used to have very subtle jokes, because he would say, he wants us to believe that medical students are dull. Only doctors who have already passed are brilliant. That's the type of joke he'll make. So when he's teaching you, because he was a gynecologist, on delivering a baby and make sure that the baby it's not short of oxygen, so there's no brain damage. If you make a mistake, the baby is going to be short of oxygen, it will be brain damage. And Mr. Pizzo will say, Dr. Pizzo will say, yes, and that baby, if you deprive her of oxygen, that baby is going to become a medical student. So you must be very careful. So how is this baby, how are we going to avoid this baby from becoming a medical student? Rather become something better in other ways. That's what you'll get, the baby will get from the healthcare system. If you contract HIV and AIDS today, what is there for you in the system? Or if you become diabetic, what is there for you? That's health service delivery systems. So these are the building blocks of the healthcare anywhere in the world. Now, why is number 4? I didn't put them in any order of importance. They are at random. But one of them I put it red there. Why is it red? Because it signifies the new apartheid that we are having. Because there is a concept which everybody, lots of people, let me not say everybody, I'll be very wrong, are attacking. The issue of NHI, National Health Insurance. Can you go back? Yes. Again? NHI, National Health Insurance. And because there's a big debate about it, everybody believes they've got a right to name it whatever they want it to be, or to define it in whatever way they want it to be defined. People believe they've got the right to do so. The World Health Organization called it universal health coverage. And many times in South Africa, you'll hear people say, no, I support universal health coverage, but not NHI. Or I don't support it in this form of NHI. It will be an animal, a person with a heart of a hyena, who can stand up and say, I don't support universal health coverage. Nobody says so. But they know very well that they don't support it. But it's better to hide and say, no, I support it, but not NHI. When actually you mean one and the same thing. So what is NHI? Move. It is, yes, it's health system financing. It's how you finance health. And in its definition, there are people who call it universal health care. It's not universal health care, it's coverage. Healthcare is there, yes, on health service delivery system, on the 6th building block. It is to do with money, dollars, bucks, rands, the yen. Yes, it's money. NHI is about money. What is it about money in NHI? It's a healthcare financing system whereby we pool funds for the whole nation, regardless of your socio-economic status, so that when you are sick, you can receive health care without suffering financial catastrophe. That's what it means. Financial risk protection. And the World Organization has already got figures. Because there is this phenomenon in South Africa which is very wrong, whereby we believe because only rich people and those with medical aid can go to a private hospital, everybody else won't go. They do, but at what cost? If they tell you that here is your daughter has got leukemia, and they put it in your head that only Dr. So and so in a private hospital can treat it, then you start believing that, of course. And they tell you they want 200,000 rand. They easily want that in private hospitals. Don't think poor people won't go there. They will. But how? They're left to sell something they own. And all over the world, people are known to mortgage their houses, sell their insurance policies, take a final year medical student out of school. Yes, because this one must leave. Or sell your livestock. That happens all the time. So the World Organization is not guessing. They've got figures. They are now in billions of people who were not classified poor before. They were living a normal life because you are aware that United Nations have got figures of what we call poverty datum line per country. That if in the country you earn so much, you receive so much per day, then you fall below the poverty datum line, you are poor. If you go this way, then you are not classified poor. I'm not saying rich, I'm saying you are not poor. Yes, because they are different. But they have got figures of people who, just because somebody got ill, they are suddenly classified poor. They are in debt, very big debt. Then they join the queue of the poor, simply because somebody got sick. Now, that's what's happening in South Africa today. The healthcare financing. And now the World Organization said, in order to bring this to an end, we need to bring a system of financing healthcare that is universal. That should not matter whether you are rich or poor. Now, in South Africa, we devised that healthcare financing system. But in the process, we completely excluded the poor. In fact, who's from UCT here? Oh, thank you. Yeah, in your university or the hospital which is attached to your university, in 1967, something there happened, which then brought me to say there are two things in South Africa which happened in 1967 that had a way of working against each other. The first thing that happened is that Professor Christian Barnard performed the first heart transplant, which has never been done in the world. He was a professor at UCT and Groote Hospital. So it's not only about KZN. Yeah. Anyway, he performed that to a working class gentleman called Louis Waskansky. Louis Waskansky was an ordinary worker. Yes, he was white, but an ordinary worker, who was told that this heart of yours can stop any time. you need a new heart. Unlike now, Louis Motsoaledi did not have to ask, where am I going to get the money to do that? There were no such questions at that time. Even Chris Barnard did not have to ask him, do you have a medical aid? Or do you have a good bank balance? Do you have a credit card? Or something? Or how much do you earn? He didn't have to ask him, because this is a human being who needs a new heart. That's all he needed. And they went to remove that heart and put a new one from a donor, etc., etc. You can no longer do that now. Yes, not in any hospital. There has to be questions about money. Now, why am I saying something else happened in 1967? Because it was the first time policies were promulgated to establish medical aid schemes, which we have got now, which is healthcare financing for a selected few, so that the Louis Motsoaledi, Professor Chris Barnard situation got completely reversed. It's no longer there. So the World Organization said, no, the world cannot be allowed to be like that. We need a healthcare financing system. Let me move. But now, before I come, again, move. Just keep on pressing or stopping. Yeah. Back, be there. Before I move further in healthcare financing, I want to tell you about this. Something in healthcare which is totally dead today. But these things are embarrassing, man. Honestly. Between the 6th and the 12th of September 1978, that is the year I did my first year. In a small town called Alma-Ata, in the former Soviet Union, before the Soviet Union collapsed, as you know, it was a union of Soviets, but now it's one country called Russia. Before the Soviet Union collapsed, there was a conference in Alma-Ata. Alma-Ata is now in a state called Kazakhstan, which is now next to Russia, but no longer part of it in that time. There was an organization called the Primary Healthcare Conference. One of the things they sought to do there was actually what is health. How do we define health? Because many people will believe that health is when you are not sick, when you are not in bed, when you are not taking injections or drugs. Is that health? And the World Organization said, no, but that's not health. Health, they say they are strongly affirming that health. It's not just the absence of disease or infirmity, but it's a state of good physical, social, and mental well-being. So you must define health in those three parameters. It's a state of physical well-being which everybody else knows. Or if you are not physically well, you are sick. And we stop there. But the World Organization says, no, you can't stop there. There ought to be mental well-being also. And there ought to be social well-being. Now, social well-being is pegged, because it means you must now have clean running water, sanitation, education. You must, you must have housing. That's social well-being. So it's not merely the absence of disease. So it's a huge definition. Then they went on to say, it's a fundamental human right, and that attainment of the highest possible level of health is the most important worldwide social goal, whose realization requires the action of many other social and economic sectors, in addition to the health sector. It's a fundamental human right, and must be chased as a worldwide social goal, which means the whole world must make it a goal to attain the highest standard of health for each and every individual. Now, Article 2 of that declaration is even more important. That conference was applied to the whole world, but I think to apply to South Africa more than any. It says the existing gross inequality in the health status of the people, particularly between developed and developing countries, as well as within countries, is politically, socially, and economically unacceptable, and therefore is of common concern to all countries. There is gross inequalities in health of human beings. Between countries is obvious. Countries in Africa, countries in Europe receive complete different social health services. But then it says even within borders of the same country, and that's what is happening in South Africa. People have got medical needs receive a totally different type of health from those who are not. So much that it has even changed the way you are taught. Because there's something they are teaching you at medical school, which you realize you are not going to find. They teach you ABC of resuscitation. When you encounter people on the road being involved in the car accident, you do ABC, isn't it? Yes, you start checking the airways, then you go for breathing, then you go for circulation of blood, and you can add delay if you have to give any drug. That is in medical school. Who is doing final year? Yes. Yes. Yeah, that's what they are teaching in medical school. Next year you are going to have to teach yourself that. Because it's not going to happen. You are going to arrive at the accident scene, the ambulance is going to arrive at the accident scene. They are not going to do ABC. They are going to go for your pocket and check. There a medical aid card. No, then this one can't go, this side must go that side. Simple. Yes. Is there a credit card? No. This side and not that side. Is there cash? Is there a bank card? That's the first thing that is checked. Which is even more evil than the manner in which people could have been segregated because of the color of their skin. That's what the World Program is talking about. They say this system is politically, socially, and economically unacceptable. And maybe you'll be surprised, what does economics do there? Because standard people can never run a country. Yes, if people are standard because they are not receiving good health care, you're not going to run a country. You can't run an economy of a country if you are standard and you've been standard by the system. Now, Alma Ata said that, and that said something very important. Health for all by the year 2000. In present day South Africa, they will laugh at you. For these people are mad. Remember, it was 1998. The year 2000 was 22 years away. And some of us who were very angry medical students said they are mad. Why didn't you so far? They must bring the date nearer. 22 years, no. It's not going to happen, man. You know? Because we thought it was far, but we believed it was going to happen. Health for all by the year 2000. Nurses through my time used to sing about it in their conference. Health for all by the year 2000. And all is all, remember. Health for all by the year 2000. It never happened. There was a big pushback from those with commercial interests. As a medical student now, you are going to support health for all by the year 2000. Because now we must choose another year. But we're going to support that concept because you are a medical student. When you start working, you develop commercial interest. You start being an enemy of that concept. Unfortunately. So some of colleagues who were saying health for all by the year 2000 with us, they are finding us to be enemies. When you talk about NHI, it is a form of health for all by the year 2000. It never happened. In many parts of the world, because there was a pushback from those who are well-to-do unfortunately. So let me go back. Go to the, yeah, up front. Yeah, move. Yeah, move. Yes. Now, I want to show you this. In 2012, at the World Health Assembly, on the 23rd of May in 2012 in Geneva, the World Health Assembly is an annual gathering of all ministers of health and experts in health, which takes place in Geneva every year. Geneva is the headquarters of the World Health Organization. Ministers get there. When they tell you a policy is from the World Health Organization, because I'm sure you've seen that in many textbooks, especially when you deal with primary health care. They say WHO. During my time, they just used to call it WHO. When they say WHO said so, then we know. Yes. Nobody else can say something else. Now this WHO, World Health Organization, the policies they put, even in medical textbooks, are actually policies that were passed by the World Health Assembly. Because that's when we make policies. We spend the whole week there, every May. It has already passed this year. It has got a Director General who is appointed by Ministers of Health. We actually sit in a hall. Many of you detest being interviewed by 5 people inside the room. To become a Director General of one organization, you get interviewed by people in a hall. Because all ministers would like to participate and fire questions at you. Yes. Now, Dr. Margaret Chan, she's from Congo. She was the Director General, and so she was opening it officially. She said, health around the world has got 7 structural problems. If those structural problems are not corrected, this concept of health for all, which we dreamt about in Al-Mahad, it's going to be difficult for it to happen. And now, those are the 7 structural problems. But I want to go to number 3. She said, because that affects my country more than any other. In some countries, there's costly private health care for the privileged few, but second-rate care for everybody else. This is the situation in our country. A privileged few, and believe me, I'm one of them. So I can say, yes, of the poor. Costly private health care for the privileged few, but second-rate care for everybody else. Everybody else must get second-rate care, but this privileged few must get costly, not just private health care. Perhaps there's nothing wrong with the way private there. The enemy there is costly. It's something that you cannot afford, it's very expensive. And so she said it's one of the problems. Can you move? The others are very clear. Now the last one, number 7. She says in many parts of the world, the rich concoct schemes for financing care that punish the poor. You start financing care in a particular scheme, but it's a punishment to poor people because they are not allowed there. And I regard medical aid as exactly that, a scheme that has been concocted to finance health care. But that's a punishment to the poor. Now what we do, move. That's why the World Health Organization came with UHC, Universal Health Coverage, to deal with that issue of health care financing. Move. Yeah, can you move? I don't want to confuse them even more. Yeah, go back. This system exists in many countries. In the UK, they call it NHS, National Health Service, starting from 1948. In Mexico, it's called Seguro Popular, meaning a popular scheme for everybody, starting in 2001. We've got in Brazil, Thailand, Norway, they call it NHI. Finland, and in Australia, they call it Medicaid. Barack Obama in America tried to bring it. And Trump told him to go to hell when Trump took over. And so they passed what they call Obamacare. The official name is affordable health care. Because health care in America is not affordable. Just money, money, money. So he was trying to do affordable health care. We, of course, want to call it NHI, which now is being fought left, right, and center, being taken to court, etc. Next. Yeah. Now, in the world, no, yes, there are three methods of financing health care. You are medical students here and leaders, very brilliant, unlike what Dr. Piso used to tell us. I know you are very brilliant. So you can come up with something I didn't know. If you do, please help me. At the moment, at my age, I only know three methods of financing healthcare around the world. I don't know the fourth one. You might have to introduce it for us. Let's move. Yeah. No, let's keep this one. We'll come back. Again. Again. These things were not done for me just Yeah, stop there. Yeah. There are only three methods of financing healthcare. The first one is mandatory prepayment of health. Firstly, it's prepayment. Pre-what? Pre-sickness. Let's pay for health before the person is even sick. It's pre. Mandatory, it means it has to happen. You've got no choice. The second one is voluntary prepayment. It's also prepayment, pay before this person is sick, but it's voluntary. You may do it or you may not do it. The third one is out of pocket payment. Out of pocket means what? Cash for health, or health for cash. I don't know. Yes. When you go to the streets now and buy a winner, there's cash first. Yes. So, out of pocket payment means that cash injection. Another cash POP, another cash oxygen, another cash Caesar. Yes. Yes. For health, or health for cash. Put it in whatever way. These are the only three methods. Now, mandatory prepayment includes the budget of a country. It includes what a minister of finance gives you. But the World Organization has moved beyond budgets of countries. And that's exactly what many South Africans who try NHI do not understand or do not know or they don't want to understand. It's not about the budget. It's about the total wealth of your country. And I'm going to come to that. Oh. Let me slow. I want to touch Aaron I want to sabotage mine. Yes. I was about to show you very beautiful bioscope. Now they just. Yes. Now, let me go on to that place of the sabotage anyway. You want to use this? Can you use this one? Yeah, but let me go on anyway. When we say mandatory prepayment of health, that's the first method of paying for health. We are saying everybody's health must be paid for before they are sick. And we include the budget in that one. That is what the World Health Organization prefer. And if you are able to do that for everybody, they call it universal health coverage. Because every person has had their health care paid for mandatorily before they are sick. Voluntary prepayment of health has got one popular name in South Africa. You know it? Voluntary prepayment of health. It has got one popular name, which everybody knows. called medical aid. It's prepayment of health, but it's voluntary. Yes, people who get into medical aid, nobody's forcing them to, except if it's a condition of your service, but even then, it's still voluntary. And the last one, out of pocket, is the most primitive method of paying for healthcare in the country. Most primitive method of allowing somebody only to put cash on the table. And it's practiced with such religion, so religious in South Africa. There are many people who died on the table only in a private hospital, where they said we want this much. Yes. Yes. A colleague of mine came home just before the election, and he was seeing tears. His brother died on the bed, on the table in a private hospital. He had a perforated ulcer, brought to a hospital which happened to be private, and they said they want 50,000 rand on the table. Otherwise, they don't start the operation. While they are still following each other around, or how do they reach that money? The person passed on. Totally against Section 27, subsection 3 of the Constitution. Please write it down and go and read it. Just like Alma Section 27 of the Constitution declared health care as a right, not a privilege for the selected few, but a right. And subsection 3 says, no one may be refused emergency medical treatment. That's what it says. If you want to know, the Constitution is lying on that one. Yes, it's lying. I'm saying so. You can put it down. The Constitution is lying on that one. If you want to test that the Constitution was lying on that one, go and fail it at the door of a private hospital. Go and pass out there. Yes. What made you pass out? Yes. Go and do voluntary passing out there. What made you pass out? And these are the things we can no longer live with, which are very embarrassing. Because how do we do such a thing? And how do you allow such a thing in this era of time, and still call ourselves a civilized nation? It can't be. So, many developed countries no longer allow that, and I've already shown you. That healthcare must be paid for before people are sick. Now, what's wrong with our system in South Africa? Why are we complaining so bitterly? I want to give you figures. We are complaining because the World Organization said in order for this health for all to happen, a country needs to spend at least 5% of their GDP on health. I'm not talking about the budget, GDP, gross domestic product. What is the gross domestic product of that country? You can't, we all know it. Can you get 5% of that? If you spend that on health, those 6 building blocks, none of them will suffer. Those 6 building blocks will all be in place if you spend just 5% of your gross domestic product on health. Now, what is the gross domestic product of South Africa? I know you're not the economist, but now I'm asking. Thank you. Yeah. Go there. Go down. Oh, no. Go up. Yeah. There's a slide, there's a one column missing there. But I want to show you something about this mandatory, voluntary, and cash. You see that slide? The World Organization call it a disaster in the making for Africa. If you are mathematically inclined, you see the disaster there. Those green bars, they represent out of pocket cash. Do you see how much health is bought for in South Africa, in Africa? Yes. Look at all those countries. Look at them. for health. Look at the last one. You see the last country? Sierra Leone. And the next one is, next to Sierra Leone is Guinea. You remember what happened then in 2018? What? They had Ebola. Yes. Together with Liberia. Those countries had Ebola. Do you know what happened? They could not be diagnosed. Because the 6 building blocks of health cannot work. There's no way they will have essential medicine and health commodities when health is financed like that. Do you see that the green line is 98% or so is cash out of pocket? There was no way. It took us. I was still a minister there in health before going to Home Affairs. NICD, National Institute of Communicable Disease in South Africa, had to get a ship, and we put a first mobile laboratory there in the ship and sent it to Sierra Leone to start diagnosing people. We were the first to arrive there. All these big countries that were willing to know and sponsor us there, but they came with big money, and we started helping them to diagnose. There was just absolutely nothing they could do. And all the rich people who were running mines, there are many South Africans who are running mines there. When they run a fever, they get into a chartered flight and come back to South Africa. The manner in which healthcare is financed. Now, there's a country there towards the middle. You see South Africa. You see, that's your country. You see that red, I don't know whether it's red or brown. It represents voluntary prepayment. It represents people on medical aid. Then the green one there is cash. And the blue one is mandatory prepayment, which means all the countries to the left. Now, if you look at the African continent, there are only 2 countries that are doing this voluntary prepayment called medical aid. It's South Africa and Namibia. And Namibians are using medical aid from here. Because they were part of us. That's why they look like that. I was going to show you a graph of other countries. Somebody stole it from my presentation. Can you go on? Yeah. Now, yes. Now, no, it's not that one. Move. This is for bigger people. Yeah. Okay, you can stop there. Yeah. Now, I want to tell you something. Because I was speaking about 5%. The 5% of the GDP in South Africa were for long considered. We're from past it. We are at 8.6% now. That's South Africa. We are spending 8.6% of the total wealth of South Africa on health. European countries on average they are at 9%. So we and Europe are in the same water when it comes to health spending. But why is it that our healthcare systems are so different? Because when big people with big pockets get sick, they run to Europe. But they are spending only 9% of their GDP on health. We are at 8.6%. And so what went wrong? The problem is gross inequality, which Alma Ata said is politically, economically, and socially unacceptable. In that 8.6%, 51% of that goes to only 14% of the population. Unfortunately, I'm one of those 14%. And you are going to be. So I'm an enemy of the people already. You are going to be enemies next year and the other year when you come, because you are going to have medical aid. Yes. 51% is spent on 14% of the population. And the remaining 49% is spent on a whopping 86% of the population. You don't have to be a medical student to know that that's absurd. It's gross inequality. And any country that calls itself civilized cannot allow that. Not with our eyes open. And how is the money spent? Let's start at the beginning. Every year, 1.2 million women fall pregnant in South Africa. Yeah. These guys here look innocent. I know them. They look very innocent during the day, but they 1.2 million women fall pregnant in South Africa every year, which means roughly it translates into 1.2 million babies born. Now, with this money, 51% of the GDP of the population is taking care of only 140,000 of them. Meaning there are 140,000 pregnant women who receive their health care in the private sector, with 51% of the total wealth of South Africa. And the remaining 1,060,000, they go and fight for that 49% that's HIV and AIDS, the biggest killer in our country. We've got 5 million people on ARVs. Almost all of them are treated in the public sector. In the private sector, I don't see as I don't want to commit myself, but it's not even close to half a million with all this money. TB, 80% of people with HIV/AIDS are killed by TB. Nobody's interested in treating TB in the private sector. Because it's not profitable. You'll never make a profit if you treat TB, believe me. Only the state can, because we are not chasing profit. In fact, if you want to die of TB, go to a private hospital, believe me. I'm not joking. You are not going to die because they refuse to treat you. You're going to die because they don't even know it. They haven't seen it for ages. Yes. They haven't. It's like malaria. If you want to die of malaria, come to Gauteng. You're gone, yes. Malaria, we are the ones who are experts in problem to malaria because we are the ones who know malaria. Yes, do that. Hey, you'll do investigation, CT scans, and all that. Die while you are still there. Yeah. But anyway, so this is the fundamental problem. The gross inequality you're talking about, if you want to see, come here to South Africa. How do you spend 51% of the 8.6% of the GDP on health on only 14% of the population? Who is this 14% by the way? People on medical aid. Yes, that is including all the doctors, nurses, police, soldiers, members of parliament, magistrates, unfortunately, even judges. You know why I'm saying unfortunately? Because the NHI is being taken to court. Judges are going to sue. Judges, but they are very efficient. It's not nice to be me. You are telling a person who's the beneficiary, that this system is evil. Yes, like members of parliament and judges have got a medical aid called permit. It's the most absurd medical aid I've ever seen. It doesn't make sense. But people with big brains see nothing wrong with it. Big brains, as in members of parliament and that. It's an absurd medical aid, you know what I mean? The whole concept of insurance, of putting funds, depends on numbers. Yes. If you join a life insurance of 10 people, if you die, you're finished. No, if there are 10 people, what are you going to get? life insurance is numbers. So that when one dies, you've got 1,000 more who pay up. Now, PARMED has got very few people. I think we are not more than 1,000. You can't have a medical scheme like that. It's absurd, it's madness. What is there? And unfortunately, big people like me are part of it. Yes. I'm a big person, by the way. Both in age and by being a member of parliament. But we are doing something very absurd. And we don't see anything wrong with that. That medical scheme should not exist at all. But it's there. And there are people who are prepared to fight for it. So this is the problem we need to solve in South Africa. When we say we want NHI, it's a secular popular of our people. A popular scheme for everybody. Now just look at that. Of course, this slide I did some 8-10 years ago, but nothing has changed. Only the numbers have changed. This is BRICS. You know BRICS countries, Brazil, Russia, India, China, before these others joined. Before Egypt and Ethiopia, Iran, and them joined, BRICS were only 5 countries. It shows expenditure. Do you see that? Total expenditure per capita in South Africa with a population of 50 million. You are aware that South Africa is a baby in terms of population in the BRICS countries. Look at China. Yeah. It's already 1.4 billion now. At that time it was 1.3 billion. Look at India. It was 1.9 billion. And then Russia 140 million, but Brazil 193. We were only 50 million, now we are 63 million. As you know. Yeah, but look at what we are spending per capita there. Do you see how high we are? China is nothing. India is nothing to us. We are next to Brazil and Russia. Now the percentage of GDP, do you see where we are? 8.5%. Brazil 9%, it's like Europe. The other members of BRICS are still very low as an expenditure. But what is that which I wanted to show you? Go. When it comes up, down, down, do you see how red South Africa is? Down, down. South Africa is red on everything. Maternal mortality, under 5 mortality. Of course, those figures were done before we started taming HIV/AIDS. So at the moment, it has improved, maybe 60%, 60 for women, 60 years for men, and about 70 for women. You see that we are red. The only time where we are as red as the other countries is in that column of non-communicable disease. You see that? That's the only one where we are better than the other countries. Why? Because developed countries have got more non-communicable diseases than European countries. Diabetes, high blood pressure, these are diseases which affect more. Yeah, you may say so. But even in this, look at TB. Look at the prevalence of TB. Do you see South Africa there? Yes, we are number 1 in the world. Anyway, can you move to the next slide? Yeah. So in short, these are the type of things that we need to correct. Now, they will tell you, you must improve the healthcare system first before you go to NHI. You must build the hospitals, buy equipment, hire more doctors, hire more nurses, make sure that pharmacies are always full. Do that first before you start this NHI of yours. If you can do that without NHI, then you don't need this NHI. I wonder whether you understand what I mean. If we can improve everything without NHI, then what do we need NHI for? Because the present system can improve everything. The fact is that it can't. And what is the reason? Human beings follow money. Anywhere in the world, doesn't matter whether in medicine or human beings follow money. If you put that 51% in that 14% of the population, everybody who is somebody will go there. And what do I mean? All the specialists will go there. All the auditors will go there. All the actuarial scientists will go there. I don't mean to get cheated. To work there. To keep the books there. To manage there. To manage the systems there. Because that's where there is money. It happens all the time. And unless we equalize in the form of AHI, it won't stop happening. Now people are saying, no, go and improve first. It surprises me. I was the first MEC for education in Limpopo. Before 1994, there were 4 education systems in South Africa. One for whites, which was on top. The second one for Indians. Then for colored, somewhere in the middle. And the last one was for Africans, called public education, which you know about, which causes way to uprising. 4 times was spent on a white child than a black child in education. The result in that dilapidated classrooms, few teachers, lowly qualified teachers, no laboratories, no libraries. That's what Bantu education schools were all about. So in 1994, you are talking mostly of Limpopo, Eastern Cape, and the rural areas of KZN. That's where it was led. But when we took over in 1994, when we had democracy, we said everybody must receive the same education system. Yes, we said so. We said you are going to write the same exam, no more exam for white, Indian, colored, and all that. Of course, I know you tell me about JMB. That is public and private. But overall, we said any person attending a public school must receive the same type of education. And at the end of the year, they must write the same exam, which is what we did. Do you see the analogy? We never said, no, we must wait until blacks have got classrooms. They were still under trees. I remember I had to buy tents for learners in Limpopo because in some villages, they didn't have trees, you know. They were chopping them and all that. We have to put them in tents, and it was very unhealthy. We never said so. We never said, no, let's wait until we've got all the classrooms, all the laboratories, all the teachers. No, we didn't. And there were teachers who were grossly unqualified, those who were trained only for 2 years. But we never said, no, let's wait for that. You know the reason why we said so? The reason is because there was a Soweto uprising in 1976. Nobody wanted to see that uprising again. That is what put you where we are. You guys wrote the same exam. And yeah, so in that regard, we're not scared of each other. More or less equal. Imagine our time I wrote Bantu education. Because the University of KwaZulu-Natal was for Indian, Africans, and colors. I was scared of them. I was scared of Indian students and color students because you get into a laboratory. You struggle there for 3 hours. They spend 30 minutes. Then you ask them, hey man, how did you finish so quick? Oh no, we did this thing in matric. No, not this thing. In matric. Oh woman. Now that I'm seeing this thing called the laboratory for the first time here, man. And, you know, so we never said no, let's build all out. Even today, we still have kids who are using pig toilet. But the education is still the same. So I do not understand this business of NHI where they say, build hospitals first, put enough doctors, put enough nurses. If we do that, we'll wait for 100 years or for another 30 years. We never did so in education. And here we are. I know it still have got weaknesses, it will take time. Because Bantu education existed for 50 years. We are now at our 30th year. We never said so. But people are saying, no, do it first. You know why? Because they know you'll never reach there. They will put you there and say, no, it's not our fault. Improve these things first. We are rejecting that in total. We will never accept that. Let me show you the last. I want to show you the last slide. Move. Yeah. Back. Back. Yeah. Now I want to show you something. This is my last slide of all the main slides. I don't want to bore you with me. I can see you're already tired. The concentration span of a medical student is not more than an hour. They never let touch me for more than an hour. Yeah. Now, around the world, there are 4 medical journals, which, if an article appears in them, is regarded as a sort of medical gospel. 4 medical journals. One of them is the Lancet. It's a British medical journal. Have you ever heard about the Lancet? You might, yes. A Lancet is British. There are 3 others. They are in the top 4. Now, in 2013, in the editorial of the Lancet in September, they argued that since human beings came into this world, health care has undergone only 2 transitions. I don't know in terms of your understanding. When did human beings come here to this planet? But since they came in here, some will tell you millions of years. Those of us who will go to church will come from the Garden of Eden and going, yeah, we'll start with Adam and Eve. I'm talking about us churchgoers, not the other Eden. Yeah, we start there. But ever since human beings started populating the planet, the Lancet said healthcare has undergone only 2 transitions. The first one, which is called a democratic transition, began late in the 18th century and changed the planet in the 20th century. What is it? Simply sanitation, sewerage, clean running water. I'm sure it sounds like an anticlimax. Instead of going to come with a brain transplant or what. Simple, just providing clean running water, sewerage and sanitation. Life expectancy improved dramatically. If you go back to read your history books, even medical history books, there's something that they don't say there but you will discover when you read cases. That women scientists, women of very high caliber, when they mention the age at which they died, they age 36 years, 40 years. You can go and check in history. Because many of them were dying in childbirth because of unsanitary conditions. Because there were no sanitary conditions and that. So life expectancy was very low, especially for women, regardless of their class. But when this demographic transition took place, that changed altogether. No more premature death. The second transition, the epidemiological transition, it's easy to explain to you. It's immunization, vaccination. Smallpox had already killed 300 million people by the time we got the vaccine. Gone. Polio. Many of you here, I wonder whether you can diagnose polio. I've got a suspicion you are going to strike. No, where have you seen it? Yes. But me, right from the time I did sub-A, it was difficult to get from sub-A to student 6 without finding a child on kindness or, that is gone because of vaccination. We no longer find kids dying of measles. Measles is there, but kids no longer die of it. Diphtheria, whooping cough, tetanus, all those are gone because of this transition, epidemiological transition. Now, they say, move. Yeah. The Lancet said, the third transition is now in the making, and it's called universal health coverage. Now the third great transition seems to be sweeping the globe, changing how healthcare is financed, and how health systems are organized. For a long time, getting health care has meant first paying a fee for the provider, a practice that effectively burdened the sick and needy people, a small and vulnerable segment of the population with most of the healthcare costs. Now, the Lancet was thinking this universal health coverage is going to spread like wildfire. It forgot that we are these people, yes, who are always there to protect money, not health. Unfortunately, they forgot that. But they were saying this transition is coming now. You may start getting worried. This gentleman here spoke about 1957. Chris Barnard, heart transplant. People can get somebody's heart and go on living. Why is it not a transition? Why is the Lancet leaving it out? Even if you were to do a brain transplant today, that won't be a transition. Even if you transplant the blood vessel, the brain. For the simple reason that the things they call transitions are not necessarily great scientific feats, are things that change populations forever. Even people who don't know that there is been a transition, their life changed without them knowing. So when you provide clean running water, sanitation, sewerage, even a person in the farm or village wouldn't know that this is the thing that they live. You'll just see their life improving. When you immunize, like we are immunizing babies, people just see measles disappearing. Even my mother could diagnose measles. Yes. Now here are medical students who can't diagnose measles. Yes. So the transitions change the whole population. That's why we are not putting scientific feet like a transplant. Now this is a transition which must happen, but we are stopping it from happening because of financial interest. Now this is the area in which you are going to work. Which side are you going to be? Who are you going to stand with? Who are you going to support in this whole thing? Are you going to subscribe to the concept of health for all by the air, what? Are you going to subscribe to the concept of universal health coverage being the third transition since human beings started populating this planet? I leave that to you, and thank you very much. Thanks for listening to me.
Thank you very much. Thank you very much. Very detailed presentation, fit for the purpose. It will be very important because the minister also acknowledged that medical students' concentration span is less than an hour. But I know it's no longer the truth. There are some that have been really